I'm just going to give you a few background points on Dr. Nathan Bryan. He earned his undergraduate degree in bachelor's degree in biochemistry from the University of Texas at Austin, and his doctoral degree from Louisiana State University School of Medicine in Shreveport, where he was the recipient of the Dean's Award for Excellence in Research. He pursued postdoctoral training at Kirschstein Fellow as a Kirschstein Fellow at Boston University School of Medicine and the Whitaker Cardiovascular Institute. In 2006, he was recruited to join faculty at the University of Texas Health Sciences Center at Houston. His 9 years there led to the discoveries which have resulted in 6 issued U.S. patents and 6 pending patents worldwide. He has commercialized his nitric oxide technology through the formation of Neogen's lab, where he's co-founder and chief science officer and has been involved in nitric oxide research for the past 15 years. We also have an exhibit booth next door. Dr. Nathan Bryan has even published a number of highly cited papers and authored or edited 4 books. Please give a warm Academy welcome to our first presentation of the morning with the title, The Role of Oral Bacteria in Systemic Nitric Oxide Production.
Thank you. Well, good morning. It's truly an honor to be here and to speak before you today. So my objectives are really clear. And so over the next hour, I'm going to be telling you really spending 15 years in basic science research and trying to condense that down into about a 50-minute talk. But really my objectives are to convince you as dentists that you're probably the most important people for treating chronic disease. We've got a number of sick people walking around, and until you clean up oral infections and get these toxins out of patients, there's no way they can get better. But I'm going to educate you on how the human body makes nitric oxide so you can begin to understand perhaps patients that present that you wouldn't otherwise make a causal relationship between their clinical presentations and the role of nitric oxide in the human body. And I'm also going to reveal to you the mechanism of action of this well-known oral systemic leak, the fact that people with periodontal disease or poor oral hygiene have a higher incidence of heart attack and stroke and really all-cause mortality through the production or disruption of nitric oxide. And then I'm going to provide you with proven science, product technology to help your patients. And in the spirit of this continuing medical education, I will not mention any products by name. I don't have financial interest in the products in my talk or a company offering grant monies for this continuing dental and medical education program. But I also have to disclose to you that as was revealed earlier, that I'm the founder and chief science officer of Neogen Labs. I receive royalties on these patents from the University of Texas and a stock owner advisor for Sage Pharmaceutical, which I'm not going to discuss that today. But as faculty and management of conflicts of interest through the university, I have to make that disclosure. But I want to start with this simple principle that a man is as old as his arteries. And this goes back to many centuries ago. And we now know that this age-dependent plaque deposition, even early teens, you start to reveal fatty streaks in the lining of blood vessels. And so over a period of many years and decades, you get this plaque deposition. And over time, this plaque becomes unstable, it'll rupture, and typically, depending on the vascular bed, it's either heart attack or stroke, and typically that's the end of the story. Through innovations in diagnostic, we have these biomarkers that can tell us at what stage of vascular disease a patient may be based on these circulating biomarkers. Early inflammatory markers such as microalbuminuria or high-sensitivity C-reactive protein can tell us a level of inflammation in patients, which is probably one of the first events in this whole atherosclerotic process. As you advance down the disease progression, you start to see an upregulation of myeloperoxidase, lipoprotein particles, and then diagnostic for acute MI is creatine kinase or troponin T. And so if those are showing up in your blood, it's signs of a heart attack. Fortunately, we've been able to assess functional nitric oxide production along the vascular tree at these different stages of vascular disease. So when we lose about 10 to 12% of our nitric oxide per decade, and it's really recognized as the earliest event in the onset and progression of cardiovascular disease. And so once you get to this stage, we think it's paramount before patients present with hypertension or full-blown vascular disease to have a functional assessment of their nitric oxide production. And then hopefully by the end of this hour, you will begin to recognize how to safely and effectively restore vascular nitric oxide production and then prevent this whole sequela of cardiovascular events. I don't have to remind you, but being in an academic medical environment my entire career and really trained in drug discovery, I think we have to look back at basic physiology and biochemistry, and good medicine is applied physiology. There's certain physiological systems that go wrong, and we just have to repair those. And I think it's safe to say that bad medicine is applied pharmacology, which unfortunately is the paradigm we live in Western medicine. So I'm going to spend the next 45 minutes talking about this single molecule nitric oxide. I've spent my entire academic career studying this one molecule, and I think with good reason, because it's now recognized as one of the most important molecules produced in the human body. The challenges in basic science and even translational medicine is to develop safe and effective nitric oxide therapeutics, because nitric oxide is a gas. So it diffuses in 3 dimensions. It has a half-life of less than 1 second. So developing safe and effective nitric oxide therapies or drugs has been very challenging. And so I'm going to take you through some of the basic science studies we've published. And I'll warn you, we're going to get into some really complicated biochemistry. But I ask you to bear with me because I will bring you back into it, and don't get lost in the complexity of it. But I do this because I think it's very important for you guys as clinicians and really on the front lines of medicine to be able to understand how the human body makes nitric oxide, how these discoveries have transformed our thinking about how the body makes nitric oxide, and then also be able to then employ safe and effective strategies to understand this and get your patients well again. And it'll probably bring back some nightmares from undergraduate biochemistry, but again, bear with me. And so with over 150,000 papers published in the nitric oxide field, it's involved in every biological function. When I started in this field in 1999, a year after the Nobel Prize was awarded, there were about 30,000 papers published in the field. Now over 150,000. And it's really recognized as a critical important molecule in the cardiovascular system. And I'll take you through that schematic here shortly. But it's also a neurotransmitter in the central nervous system. It's critically important in regenerative medicine. It's the requisite signal that tells our stem cells to mobilize and differentiate and to repair tissue. It's critically important in the urogenital tract. It's the molecule responsible for sexual function, erections in both men and women. And in fact, sexual dysfunction is really one of the earliest presentations of insufficient nitric oxide production. As I mentioned, the Nobel Prize in Physiology was awarded in 1998 to these 3 U.S. scientists. Ferid Murad had discovered in 1977 that drugs like nitroglycerin that had been used for about 150 years prior to the 70s for the treatment of acute angina worked because these drugs were metabolized into nitric oxide. So when nitric oxide is produced, it dilates the coronary arteries and relieves this ischemic pain that's called angina. In 1980, Bob Furchgott discovered that our endothelial cells makes a substance that makes blood vessels dilate. He didn't know what this was, so in his 1980 Nature paper, he termed this endothelium-derived relaxing factor. So the name itself implies what it does, but nobody knew what EDRF was. And then Lou Ignoro, 7 years later in 1987, discovered that EDRF is nitric oxide. And so whether you give nitric oxide as from an exogenous source such as organic nitrates, or you stimulate endogenous nitric oxide production, dilates blood vessels, improves perfusion, reduces blood pressure, and really elicits this extremely cardioprotective phenotype. I've been fortunate to work with all 3 of these giants in the field. Bob Furchgott since passed away, but it was Fred who recruited me to faculty at University of Texas Medical School back in 2005. And I'll take you through, again, some of these studies that we published together. And then Lou Ignoro has written the foreword to a couple of my textbooks. This was the front page of the New York Times the day the Nobel Prize was awarded by Val Fuster, that the discovery of nitric oxide and its function is one of the most important in the history of cardiovascular medicine. And for years we've thought this, but I show you this because I think you can't overemphasize the importance nitric oxide has on the cardiovascular system, the cardiopulmonary system. So this was a paper published by a good friend and colleague last year by Jonathan Stammer. So what this study told us unequivocally is that nitric oxide is critically important and required for oxygen transport and delivery to the periphery. So nitric oxide can bind to hemoglobin, a critical cysteine residue on hemoglobin, and if there's no nitric oxide bound to that hemoglobin, then oxygen can't be delivered from hemoglobin to the periphery. So it's critically important in this R to T state transition that delivers oxygen to the capillaries, picks up carbon dioxide, and involved in the cardiopulmonary system. So really the pulmonary system is a three-gas system. It's oxygen delivery, CO2 uptake, but also nitric oxide required for the delivery of that oxygen to the periphery. And I just want to take you through the functional schematic of how nitric oxide is produced. So the most potent agonist is shear stress. So when we begin to exercise, that's why exercise is cardioprotective, that it stimulates this enzyme, nitric oxide synthase. And this enzyme converts arginine to nitric oxide. As I mentioned, nitric oxide is a gas, so part of it diffuses into the lumen of the blood vessel, which will be here. It interacts with platelets, monocytes, neutrophils, and prevents these white blood cells and platelets from sticking to one another. But part of it also diffuses into this underlying smooth muscle, where it activates an enzyme that Ferid Murad had worked on for a number of years called guanylyl cyclase. And then this enzyme produces cyclic GMP. Again, don't get bored down into the details, but I show you this because some of you are familiar with this pathway, you just don't know mechanistically how it's working. Because PD5 inhibitors, such as Viagra, Cialis, and Levitra, prevent the breakdown of cyclic GMP. And that's why they're warned against 4-hour erections. That's why you're warned against the 45-second commercial is filled with 40 seconds of disclaimers. Because if you're taking an organic nitrate, then you can get systemic vasodilation, you'll pass out. But the interesting thing about these drugs is that they only work in 50% of the men in which they're prescribed. So a multi-billion-dollar-a-year drug only works in 50% of the patients. And the reason for that is that without any cyclic GMP produced, these drugs have no substrate to work on. And so without nitric oxide produced, there's no cyclic GMP. So the root cause of erectile dysfunction is insufficient nitric oxide production, not overactivity of a phosphodiesterase enzyme. So my focus for the past 15 years has been, how do we fix this? Because if we fix this here, we fix this enzyme and give the body nitric oxide, it will always respond. And so really, when you do that, you get to the root of the problem. And this just shows you a schematic of patients with angina. You can see the occluded coronary artery. If you give transdermal nitroglycerin, that it releases nitric oxide, dilates the blood vessel, and mechanistically, that's how it works. So the fundamental question we asked over 15 years ago was, how do we control and regulate nitric oxide production? Because once we understood this, then we can begin to delve into individual patients, figure out what goes wrong in these patients, and then fix it. And this is the complexity that I talk about, because for years people thought, well, I can just give my patients L-arginine because it's a precursor to nitric oxide. Well, that's fine in young, healthy individuals with a good endothelial function. But this is the most complex reaction in the human body. This is what we call a 5-electron oxidation of this guanidino-nitrogen. And through a multi-step oxidation reaction generates nitric oxide. But it's the only human enzyme known to require 8 different cofactors and substrates, from oxygen, glutathione, tetrahydrobiopterins, flavin-dependent cofactors. So if any of these become oxidized, the enzyme becomes uncoupled. And if you give arginine to a patient with an uncoupled nitric oxide synthase enzyme, you actually stimulate superoxide production instead of nitric oxide production. There's a number of clinical trials out there now showing that high-dose L-arginine in PAD patients and post-infarct patients actually causes more harm than good. So this was a very naive and perhaps dangerous strategy early on before people realized what goes wrong in the enzyme that makes nitric oxide. We can actually extend the biological half-life of nitric oxide from 1 second out to about tens of minutes or hours because it'll bind to glutathione. So glutathione is critically important for the production of nitric oxide, but also for extending the biological half-life of nitric oxide. We've identified these novel inhibitors of the metabolizing enzyme, and that's the basis for the Sage Pharma technology, which we're developing is for airway inflammation, asthma, and COPD. But I'm going to spend a lot of time today talking about the role of oral bacteria in the recycling of nitrate, nitrite back to nitric oxide. And as I mentioned earlier, this is the age-related decline in nitric oxide production. This is from a population-based, from 4 independent studies looking at the age-related decline in nitric oxide production. So by the time we're about 40 or 50 years old, we have about 50% of the nitric oxide we had when we were younger. So no wonder about the age of 40 we start to feel the effects of aging. We don't perform as well in the athletic field, the boardroom, or even the bedroom. And then you see that premenopausal women are a little bit more protected in terms of their nitric oxide production because of the positive effects of estrogen on stimulating nitric oxide production. But at menopause, they lose these effects and nitric oxide falls precipitously. So our thought over these past decades have been, can we prevent this age-related decline in nitric oxide production? Or at least shift this curve to the right, because if the literature is correct and true, it will tell us that if we can prevent this age-related decline in nitric oxide production, we can prevent age-related disease, from type 2 diabetes, hypertension, peripheral artery disease, even vascular dementia, and even Alzheimer's. And so I don't have time to take you through all those trials today, but it's suffice it to say that we've been able to demonstrate this by restoring nitric oxide. So what are the consequences of insufficient nitric oxide production? You guys probably see these patients every day. They have high blood pressure, they have advanced vascular disease, thrombosis, coagulopathies, Alzheimer's, ED, PhD, immune dysfunction, even uncontrolled cell proliferation, because nitric oxide puts the brake on the cell cycle, and then chronic inflammation. So this is a busy slide, but it's just to remind me to tell you that it's the medical literature that tells us that the inability to make nitric oxide is the first event in the onset and progression of cardiovascular disease. But it also has very predictive value for detecting future atherosclerotic events. So once we know how the body makes nitric oxide, we're really left with finite strategies to restore and replete nitric oxide. Again, if you have a functional nitric oxide synthase enzyme, you can give moderate doses of L-arginine and see a little bit increase in nitric oxide production. You can give antioxidants to keep these cofactors reduced and preventing oxidation. But there's also NOS-independent sources of NO. There's nitrite, nitrate from our diet, green leafy vegetables, and I'll spend some time on that. Nitro fatty acids, hybrid drugs, which pharma has been trying to develop for a number of years. But now I want to shift gears and take you through just a couple of papers we published about a decade ago that really changed the way we thought about nitric oxide. I'm from Texas. I'm a very simple guy. I ask very simple questions. And the question we asked was, if we increase nitric oxide production in the heart, can we prevent injury from a heart attack? And then if we could do that, could we trace this phenotype biochemically to give us some type of biomarker that we could assess to maybe tell us who's at risk for a heart attack? And we do this in basic science through genetics. So we can create these transgenic mice where we overexpress the nitric oxide synthase enzyme only in cardiac myocytes, and this will take you through some really boring biochemistry, but the reason I show you this is that to convince you the transfection was successful and this enzyme is functional because it's generating nitric oxide. And if we take these mice and we do open heart surgery on them and we occlude the left anterior descending artery, the LAD, for 45 minutes, and then reperfuse for 24 hours, which mimics a human heart attack, then these mice see no injury. Their heart, there's no infarct in the heart. The echocardiographic data of the heart reveals that it functions very normally. So this is the first demonstration that if you generate nitric oxide in the heart and you subject the human, or in this particular study, a mouse has a heart attack, you can protect the heart from injury. The interesting thing for this, when we followed up on this, we were interested in what's happening in other tissue. We never look at a single tissue in isolation, especially in these in vivo models. So we took the liver of these mice and found that the liver biochemistry was changed. But this was a little bit perplexing to us because we knew that the half-life of nitric oxide is 1 second. So nitric oxide couldn't survive transit from the heart to the liver to mediate this change in biochemistry. So something was mediating this endocrine function of NO. Then the next question is, well, does this mean anything? And so if we cut off the blood supply to the liver for 1 hour and then reperfuse for 5 hours, you can see that the liver is protected from injury by virtue of these liver enzymes. And so we published this in the Proceedings of the National Academy of Science in 2008. It took us over 2 years to get this published because none of the reviewers believed what we had demonstrated, that there was a hormone function of nitric oxide. The nitric oxide produced in a single biological compartment could mediate effects distally. Created in the heart could protect the liver from injury. And so understanding that, I knew that all we had to do was generate nitric oxide in a single biological compartment and understand the oral cavity is our most non-invasive, accessible biological compartment. And so if you can generate nitric oxide in the oral cavity, you can protect the heart from injury from heart attack. You can protect the liver from ischemia reperfusion injury. So the interesting thing then was we focused on food because we knew that diet and lifestyle is the most effective way to prevent cardiovascular disease, really all disease. But mechanistically, nobody knew how this was happening. People thought that it's the vitamins and minerals and antioxidants in green leafy vegetables. But it was revealed over the past 15 years that there's a missing nutrient in these clinical studies, and it's inorganic nitrate, which is found in green leafy vegetables. And in 1978, it was recognized that our salivary glands concentrate nitrate, inorganic nitrate. And the cancer biologists didn't understand this because they thought that nitrates form nitrosamines and would cause cancer. So why would our body intentionally put nitrate in our salivary glands? Well, about 10 years ago, we discovered that there's oral nitrate-reducing bacteria that reduce salivary nitrate to nitrite. Humans don't have this enzyme, so we're 100% dependent upon oral bacteria. And then every time we swallow our saliva, the nitrite in our saliva reaches an acid pH and generates authentic nitric oxide gas. So our mothers were right when she said, eat your vegetables and don't spit. Because when you do this, you're fueling this nitric oxide production in a single biological compartment. And there's a number of studies out there showing that you can prevent even H. pylori overgrowth, prevent gastric ulcerations from chronic NSAID use, enhance gastric mucosal blood flow simply by fueling this pathway. And I'll get to this later, but people who use proton pump inhibitors to suppress stomach acid production is a very, very bad idea and probably one of the public health issues we face today. So going back to this heart attack model, we thought, well, that's cool and perhaps has some utility, but the heart attack is really the manifestation of years of typically bad diet. We can't blame genetics anymore because of this whole epigenetic regulation. We can turn genes on and off. So that's no longer an excuse. But what we knew was that if you could prevent the earliest stages of atherosclerosis, which is characterized by monocytes and neutrophils that stick to the lining of the blood vessel, and then they migrate through, it elicits an immune response, they develop these foam cells, and over time you develop plaque. Plaque becomes unstable, it ruptures, and that's the end of the story. But it's also recognized that if you can prevent this, you can prevent the progression of vascular disease. So we did a couple of cool studies, and this is real-time intravital microscopy of a vascular bed fed an atherogenic diet. So you can see here these monocytes and neutrophils that have stuck to the lining of the blood vessel. There are a number of cells that have migrated through, but you can see this is a heightened state of vascular inflammation. If we give that same atherogenic diet, but we give a source of nitric oxide, you can see you completely suppress the vascular inflammation. The blood vessel is actually more dilated. The monocytes and neutrophils home along the vascular endothelium, looking for sites of injury, looking to do their job, but they don't stick. So you completely suppress the vascular inflammation. So if you choose to eat a poor diet, atherogenic diet, you better make damn sure you have some nitric oxide on board to prevent these blood cells from sticking. There's a number of studies now, really after the 2012 Olympic Games, it was recognized that you could actually give inorganic nitrate. A lot of people were drinking beetroot juice during the Olympics to enhance their performance. A number of studies showing that if you drink beetroot juice, you could reduce blood pressure. And so to understand this, we started trying to figure out, because humans can't metabolize inorganic nitrate. This is a bacterial pathway. And so this study shows that if you take normal-tensive, healthy individuals and you give them chlorhexidine twice a day for 7 days, their blood pressure goes up. And this drives vascular biologists and cardiologists crazy because you're affecting bacteria and it's making blood pressure go up. Well, we began to investigate, and really spent the past 5 years of my academic work trying to figure out which bacteria are necessary for this. And it shouldn't be surprising that bacteria provide us with metabolites and substrates that humans can't do. And the fact that humans only have about 23,000 genes, but the bacteria that live in and on our body have 3 million genes that are actually doing things that the human body. So it's a true symbiotic relationship. And this is really illustrated in the fact that these bacteria have a nitrate reductase, nitrite reductase, nitric oxide reductase, so they can reduce nitrate all the way down to elemental nitrogen or ammonia. The reverse of this is the basis for fertilizers. You add ammonia or nitrogen, and these bacteria or bugs that live in the root nodules of plants actually fix nitrogen. So these are denitrifying bacteria. So we begin to collect tongue scrapings from people walking around the Texas Medical Center to figure out what's growing in these people's mouth, and then could we correlate certain bacterial communities with steady-state blood pressure. And I can't show you all this because there's a number of patents that are in the process of being filed, but this is really shows you the example of the effects of this. So we took a normotensive, this is a dental student at UT Dental School, and put him on chlorhexidine for 7 days. His blood pressure increased 26 millimeters of mercury. And then every day we do tongue scrapings and culture these bacteria, and we're able to correlate the repopulation or recolonization of 1 or 2 bugs with the normalization of blood pressure. So we're really paring down which bugs are necessary and sufficient for maintenance of normal blood pressure. We published we identified probably 15 or 16 of these several years ago, and we published these. But the people that have the right, certain populations and microbial communities, these best nitrate reducers is what we call them, have lower blood pressure. People that are worse reducers have higher blood pressure. So we think we can use this as a diagnostic for putting people, maybe an additional risk factor for cardiovascular disease. And again, going back to, and we're also uncovering that people with periodontal disease or gingivitis, even though it's a different surface in a different community, these gingival bugs are affecting the bugs in the crypts of the tongue, what we're interested in. So I think with disrupting these bacteria, either through poor oral hygiene or too good oral hygiene by using mouthwash every day, you begin to disrupt these bacteria, affect nitric oxide production, and you're at risk for cardiovascular disease. So just as in the nitric oxide synthase pathway, you can disrupt this. I think a strong argument could be made that we're a nitrate-deficient society. We don't eat enough green leafy vegetables. The transporter has been identified. People with solid disease like this, insufficient saliva production, lack of oral bacteria. Even we're finding that the use of antibiotics disrupts these communities. Active dental infections and insufficient stomach acid production. So if you have patients who are doing all this, you can begin to interrogate at each step and realize that they may be nitric oxide deficient. So this just kind of hammers home the idea that absence of these bacteria may be a new risk factor for cardiovascular disease. We're trying to develop these rapid diagnostics through tongue scrapings to figure out which people may or may not have these. I think use of antiseptic mouthwash, specifically chlorhexidine, is probably a very bad idea. Patients taking PPIs to suppress stomach acid production disrupts this. And in fact, when this paper was published several years ago, that acid reflux drugs may cause heart disease. People who have been on PPIs for 3 to 5 years have a 30% higher incidence of heart attack and stroke because it's disrupting nitric oxide production. I'm going to move quickly through diabetes because I want you to understand the importance of nitric oxide in type 2 insulin-resistant diabetes. We've known for a number of years that once patients get diabetes, it suppresses nitric oxide production. And people don't die from diabetes. They die from the vascular complications of diabetes and through the disruption of nitric oxide production. When you knock out the nitric oxide synthase gene in mice, they develop type 2 diabetes. So this was the indication telling us that perhaps loss of nitric oxide production leads to insulin resistance type 2 diabetes. So you have this perpetual cycle. And I'll go quickly through this, but the purpose of this is to show you that if you take these enos-deficient mice and you simply give them inorganic nitrate in their drinking water at levels that a human could consume through inclusion of more green leafy vegetables, you can see they gain less weight even though they're eating the same amount of food, about 50% less of visceral fat deposition. Glucose tolerance improves, hemoglobin A1C reduces by 50%. The ratio of proinsulin to insulin improves, and you get better management of blood pressure. So it appears that you can overcome an enzymopathy, a lack of nitric oxide synthase enzyme, simply by giving inorganic nitrate through the drinking water. Now, that was an important observational study, but it didn't tell us mechanistically how this is happening. And I'm a biochemist by training, so I'm interested in exactly where in this pathway is nitric oxide affecting glucose uptake. And so you can see here, this is actually complicated, but it's really a simplified schematic, that when insulin binds to the insulin receptor, it activates these kinases, and then these will phosphorylate nitric oxide synthase enzyme, make nitric oxide. But in the literature at that time, it didn't tell us how that was affecting glucose uptake. So we engineered some cells that had green fluorescent protein, so we could actually look at the fluorescence of these individual cells that were tagged to GLUT4 and see what's happening to GLUT4. And so I don't know if the lighting will allow, but you can see here if you stimulate with NO-bound to glutathione, you can see that the periphery of these cells start to light up. So GLUT4 is a cytosolic protein. When you stimulate it with nitric oxide, it goes to the membrane, binds glucose, and enhances glucose uptake. So in diabetics, if the enzyme doesn't work, it can't make nitric oxide. GLUT4 never gets the signal, so you develop type 2 insulin-resistant diabetes. If you restore nitric oxide production, you restore that pathway. And mechanistically, again, we published this several years ago, but there's two cysteine thiols for those of you interested in the basic biochemistry, but you can modify these cysteine residues and enhance the glucose uptake through nitric oxide. I'll switch gears just for a second, and again, this is a lot of information, but I think my point is to give you really 15 years of work and the basis for really how you implement this in patients. But traditional Chinese medicine, in the drug discovery program we had with Ferid Murad at UT, I was screening natural product libraries. So plant libraries from Harvard, some we brought back from China, and trying to figure out if some of these medicines work because they had some nitric oxide activity. And so I had a postdoc in the lab. We sent him to the acupuncture shop, and I said, only bring me herbs or medicines that you would use for a cardiovascular patient with hyperlipidemia, high blood pressure. And so we did this old school. We'd get a mortar and pestle. We'd grind these herbs up, and then we'd put them in our nitric oxide analyzer. And this was shocking to us. Some did nothing. There was one extract that we could see. It generates nitric oxide. You take it out, it goes down. We put another one in, you get a spike of nitric oxide, and has a sustained nitric oxide release profile. And then we had this crazy idea. I said, well, let's add these together. We put these two extracts together, and you get this. So we could quantify the synergy that's been described for traditional medicines for centuries, simply by its ability to generate authentic nitric oxide gas. And so to demonstrate if they were biologically active, we fed these to ApoE knockout mice, and within 6 weeks, we could restore about 50% of their endothelial function. So the next, what I want to do is take you through the diagnostics. How do you measure? There's not any standard labs that you can pull peripheral blood and send it to LabCorp and get markers for nitric oxide. But there's these functional devices that you can do. This is a endothelial test. So you apply a blood pressure cuff for 5 minutes, you release it, and then measure the change in temperature. And this is my endothelial function, and it's good, or I wouldn't show you this slide, but you can see this gives you a pretty good assessment. And these are non-invasive, really cool tools you can use for assessing nitric oxide production. This just shows you that as you increase your cardiovascular risk, it leads to a stepwise decrease in nitric oxide production. And then we've also developed some these salivary diagnostics that you can use kind of as a proxy for total body nitric oxide availability. I show you this because the ability to, so we've focused on the fact that foods are cardioprotective through this pathway, but exercise is critically important as well. Your ability to generate nitric oxide predicts how well you can perform. So no wonder these Olympic athletes were drinking beetroot juice to enhance their nitric oxide production, because mechanistically it improves blood flow and perfusion to working skeletal muscle. It enhances mitochondrial ATP production and actually induces mitochondrial biogenesis. So the net is you have better blood flow, more mitochondria generating ATP more efficiently with less oxygen. The problem is in older patients, and these are patients who are undergoing an exercise stress test, that their coronary arteries aren't able to make nitric oxide. So they fail the exercise stress test. They're typically wheeled upstairs, cracked open, or put metal in their arteries rather than getting to the fundamental basis. I mean, some of these are life-saving procedures, obviously, if it's too advanced. But here's kind of what our working model in terms of enhancing nitric oxide production. Obviously, you can, if you have a functional nitric oxide synthase enzyme, you can utilize arginine that's already in the cell to make nitric oxide. Reacts with oxygen to form nitrite, reacts with oxyhemoglobin to form nitrate. But nitrate's also in the foods we eat, such as beets, kale, lettuce, a lot of green leafy vegetables. And despite what we've been told for 50 years, that nitrite and nitrate don't come primarily from cured and processed meats, which we've been told to avoid, 85% of our nitrate and nitrite burden comes from green leafy vegetables. And all the epidemiological data demonstrate that green leafy vegetables have anti-cancer effects and extremely cardioprotective. Only 5% of the nitrite and nitrate comes from eating processed meats, and the other 10% comes from swallowing our own saliva. So that's the basis, the physiological basis for doing this. We've recognized that there are these facultative anaerobic bacteria that we've identified that can facilitate this first 2-electron reduction. If you don't have these bacteria, you can eat kale or beets all day long, but you're never going to get a nitric oxide benefit. The other important component here is that we've identified these natural products that reduce nitrite to nitric oxide, so we can generate nitric oxide at any rate, at any level along the physiological oxygen gradient in humans. And I'm going to take you through 4 or 5 clinical trials, and I'm going to sum this up and bring it all back together for you as practitioners on how you can implement these findings in your practice. But I want to remind you that we really don't have to be that good at lowering blood pressure to reduce the incidence of heart attack and stroke, because just a 5 millimeter reduction reduces the risk of stroke by 34% and ischemic heart disease by 21%. And this was a trial published in 2011 demonstrating that as you can generate authentic nitric oxide gas in the oral cavity. This is an orally disintegrating tablet that's activated by your saliva. This natural product chemistry comes in contact and it generates authentic nitric oxide gas. So again, getting back to this concept that if you generate nitric oxide in a single biological compartment, it'll have hormone-like functions, be transported throughout all tissue, and you can mediate some cardioprotective and anti-inflammatory effects along the vascular. The interesting thing about this was we sent this off and basically looking for safety considerations. The only thing that showed up was about a 27% reduction in triglycerides. So in patients who have triglycerides greater than 150, 30 days of nitric oxide therapy would reduce their triglycerides by 27%. Highly significant effect on triglycerides. No effect on cholesterol or LDL and HDL, which I think is important because we're beginning to realize that cholesterol was never our enemy. We need cholesterol to make sex hormones. We need cholesterol to make vitamin D. And I think taking cholesterol-lowering drugs is a very dangerous concept because we have an epidemic of low T, low vitamin D, and even type 2 diabetes with these statin uses. The next study was a double-blind, placebo-controlled crossover study, seeing how this is affecting vascular function, in the form of ultrasound of the carotids, systemic blood pressure at 30 and 60 minutes, a pulse wave analysis after 30 minutes, and then 4 hours after that, have we done what we set out to do, is fix the enzyme that makes nitric oxide. So 4 hours after this, have we recoupled the enzyme, allow a 3-week washout, cross the patients over, and then repeat with either the placebo or the active. This is the data that was published in the Journal of Clinical Hypertension several years ago. These are unmedicated hypertensive patients. A single nitric oxide dose would reduce systolic and diastolic blood pressures by 4 to 5 millimeters of mercury. Again, as good as any FDA-approved prescription antihypertensive medication. And then 4 hours later, you see about a 15% improvement in endothelial function. So again, demonstrating that we've actually recoupled that enzyme, and that enzyme can actually now utilize arginine to make nitric oxide and dilate the blood vessel. The interesting thing, and I think perhaps one of the most important in terms of safety considerations, is that the higher the blood pressure, the bigger the effect. If you have normal blood pressure or low blood pressure, there's no further reduction in blood pressure. And this is what has led to, I think, unsuccessful therapies, because if you give nitric oxide the way that Big Pharma wants to do this, it leads to systemic vasodilation. People get low blood pressure, orthostatic hypotension, and syncope, and they actually pass out. So this, I think, is delivering physiological amounts of nitric oxide through this endocrine effects. And then if we look at the left common carotid, you can see baseline internal diameter of about 0.52 centimeters. 10 minutes later, the blood vessels dilated to about 0.6 centimeters. And if you employ Poussali's law, which is the simple laws of hemodynamics, this 13% increase in blood vessel diameter translates into a 34% increase in blood flow. So no wonder vascular dementia patients begin to improve their cognition, and because they're perfusing certain regions of the brain, in this particular case, by restoration of nitric oxide production. And this just shows that every patient responds. So I think this is an important concept because it tells us that the body never loses its ability to respond to nitric oxide, it loses its ability to make it. And if we give the body nitric oxide, it responds, it dilates. And you can see here, some of these patients had about 40% stenosis of the left common carotid. But even though there's plaque built up, the blood vessel still dilates and improves perfusion. This was looking at augmentation pressure, or index, which is a measure of vascular elasticity or stiffness. Central aortic pressure decreases, but this augmentation index, which is a measure of arterial compliance, so with each heartbeat, you get this pulse wave that travels along the vascular tree. If you have stiff arteries, this pulse wave travels real fast. If you've got soft, compliant, flexible arteries, it dampens this wave with every heartbeat, and it's protective. And so we see about a 60% improvement in augmentation pressure within 30 minutes. The next trial was in pre-hypertension, and this is an untreatable condition. It's recognized that 1 out of 3 people have full-blown clinical hypertension in the U.S., and 1 out of 3 people have pre-hypertension. So 2 out of 3 people, or probably 300 or 400 million people in the U.S., have pre-hypertension or hypertension. For pre-hypertension, you're told to lower your sodium intake, change your diet, get moderate physical exercise, but compliance is an issue. Who wants to do that? So in 6 months, typically 95% of these pre-hypertensive patients become hypertensive. So we thought, can we reverse that trend? And the data demonstrate that we can very effectively reduce that trend. So within 30 days, we took 100% of pre-hypertensive patients and made them normotensive. The degree of that reduction was in 30 days, we reduced systolic blood pressure by 12 millimeters of mercury, diastolic blood pressure 6 millimeters of mercury. No change in heart rate. 6-minute walk test, the patients on the actives actually were able to walk significantly further, indicating an improvement in the functional capacity of the heart. And then these quality of life questionnaires demonstrated that they felt better both from a mental and physical composite score. This is brand new data that was just published about a month ago, but this is by Ed Lee, an endocrinologist in Orlando, who took patients who have had stable carotid plaque for 3 years. The only thing he did differently was put them on some nitric oxide technology, and then brought them back 6 months later. We see about 11% plaque regression in these patients. And if you compare that to aggressive statin therapy, statins can reduce plaque by about 2.5% within 2 to 3 years of aggressive therapy. So 11% regression in 6 months as opposed to 2.5% over 3 years with statins. This is just some cool imagery. You can take patients with Reno syndrome with the cold hands, cold feet, restore nitric oxide, and you start to perfuse the microcirculation. And then I'm going to end with 2 case studies that are extremely near and dear to me. This one is probably the most gratifying thing I've done in my career, because working in the Texas Medical Center, you have the chance to collaborate with a lot of physicians, and there's a group of pediatric patients at Texas Children's Hospital where the world's experts are in these urinary cycle disorders. It's a group of patients who are born without this enzyme, arginosuccinate lyase, and they develop hyperammonemia. And they present, this is part of newborn screening now, but years ago it wasn't. And so these patients would present typically with hyperammonemia that have liver disorders, resistant hypertension. And so the pediatrician at the time contacted me and said, we need help figuring out these patients, because even though we're controlling for the recurrent hyperammonemia through diet and through medication, these patients are still dying of liver function and cirrhosis at 7 or 8 years of age unless they get a transplant. They present with blood clotting disorders, neurological dysfunction that appeared to be independent of the recurrent hyperammonemia, resistant hypertension. They were spilling protein in their urine. And so the question was, is this more than hyperammonemia? And the answer was yes, it's a disruption in nitric oxide production. And I don't have time to take you through the details of this, but we published this in Nature Medicine, mechanistically what's happening in terms of nitric oxide. But this is the pediatric patient that we saw in February of 2010. He presented to Texas Children's, a 15-year-old kid, and he had blood pressure of 180 over 120. He was put in the pediatric intensive care unit, and you can see here he was put on standard antihypertensive medication. But even though he was treated very aggressively, his blood pressure was uncontrolled. We knew at that time it was a nitric oxide problem, so his treating physician gave him isosorbide, which is an organic nitrate similar to nitroglycerin, and his blood pressure responded very nicely. And this kid did really well for about 6 months, and then his blood pressure started creeping back up. And that's common with these organic nitrate drugs, that they're great for acute use, but you can't use these chronically because of tolerance development. About a year to the date, he showed back up at Texas Children's. He was taking 20 milligrams 4 times a day. His blood pressure was 185 over 115. When we saw him, we gave him some nitric oxide, and his blood pressure within 4 hours was 135 over 80. We're now 5 years out. This kid is off all prescription medication. He graduated high school. His left ventricular hypertrophy completely remedied. This was on ABC Headline News, I think, with Barbara Walters. This was a great success story for this single kid. And these are the, thank you. And these are the nice emails you get from the parents who truly, you've certainly changed their lives. But here the mother talks about him playing chess with his dad. So not only are we affecting his vascular performance and his blood pressure, but his cognition seems to be improving. Here, the mother talks about him just actually beating his dad in chess this night. So hopefully I've convinced you that nitric oxide is critically important, but it's not the end-all, be-all, cure-all. And I think as scientists, and probably as many healthcare practitioners in the field, we forget to put the pieces of the puzzle together. We all go to these meetings, we learn something new, but we'd never implement it because you have to restore the physiology. So now I'm going to take you through one last case report to show how fixing oral infections and using restorative dentistry with the nitric oxide and some voltage with humic fulvic acid to really get to the basis of cell biology, how you can affect really a critical burn. And this gentleman here is my dad. He's a paraplegic from a car accident in 1984. So for 30-something years, he's been rolling around in a wheelchair. And he had a hemorrhoidectomy surgery, I guess about 4 years ago. And the surgery didn't heal well, so his surgeon told him, well, go home and sit on a heating pad 30 minutes a day. And when you have a paraplegic diabetic, this is the results of a third-degree burn from sitting on a heating pad trying to heal a botched surgery. So obviously this was a critical situation by the geographic location of this, certainly prone to infection. The physicians at BAMC in San Antonio said that this wound would probably never heal, probably succumb to the infection. But we started employing the basics of cell biology using voltage, nitric oxide to get blood flow to the wound, and the humic fulvic acid to give the raw materials that a cell needs to regrow. And within 3 months, we had the wound completely healed. And the surgeons couldn't believe this, had never seen anything like this, even at Brooke Army Medical Center in San Antonio, who treat critical burns all the time. The interesting thing about this wound was there are these decubitus ulcers that form, and so when they graft over this wound, my dad had the decubitus ulcer that formed, and this was a picture of it. This is on the right. I could fit almost a softball into this wound, and again, the best wound care docs that we went to told us that we could probably never get this wound healed because of all the comorbidities and dad being a diabetic paraplegic. Again, going back to the principles, we used ozone to kill infections, we used humic fulvic acid, we used nitric oxide, we used voltage to get this wound healed, and within 6 months we had this 95% healed. So again, going back to really the direst situations clinically, if we utilize the basic principles of physiology and understanding, and again, it's worth mentioning, my dad had a lot of mercury amalgam fillings in his mouth. He had metal crowns, infected root canals, and so he didn't start healing until we cleaned up his mouth. So let me just end with what I've hoped I've convinced you of, that if you give the body a source of nitric oxide, it will respond. We've learned how to fix the enzyme that makes nitric oxide in the vascular endothelium, and really living by the principles that if you give the body the nutrients it needs, then it will repair itself. I think it's safe to say that we know what the body needs to make nitric oxide, and we can do that. Plant-based natural product chemistry is actually very important. No tolerance development, 7 issued patents, and 9 more pending. So the question we have to ask ourselves is, who needs nitric oxide? And I think a strong argument could be made that if you're aging, you need nitric oxide because of this age-related decline in NO. Certainly anybody over the age of 40. Poor oral hygiene. I think we're going to get a grant funded from NIH. We're trying to investigate the role of the oral bacteria in resistant hypertensive patients, and then trying to figure out how do we replete these oral bacteria, and how gingivitis or periodontal disease, again, the bugs in a different part of the mouth are affecting these nitrate-reducing bacteria. Certainly anybody with circulation issues, diabetics, low energy, sexual dysfunction, and anybody on an acid. So these proton pump inhibitors completely shut down nitric oxide production. So if you can't get your patients off PPIs, you have to give them supplemental nitric oxide to overcome the unintended effects of antacids. Or really anybody interested in disease prevention, because if you can prevent the loss of nitric oxide production, you can prevent a lot of these age-related disease. So just let me conclude that hopefully convince you there are profound effects of nitric oxide on health and disease. Recognizing this early on, before ideally the presentation of symptoms or disease is critical. Again, it goes back to keeping it simple, is lifestyle modification. Change of diet, moderate physical exercise, fixing that enzyme that makes nitric oxide, and then really putting the pieces of the puzzle together and recognizing what does the body need to make new cells that work properly, and then implementing the basics of physiology and cell biology. Identify the cause of disease, remove the toxicant. I think you guys in the room are probably the best in the world at that, understanding what's causing these problems, and then restore the physiology. And I'll just leave you with a couple of references. This is a book we wrote several years ago. It's a lay version trying to educate the masses on nitric oxide. For those of you interested in a more technical read, this is an edited book that I edited with Joe Scalzo, who's chair of medicine at Harvard Medical School and chief of cardiology at the Brigham. The second edition of this book will actually be out probably in 3 or 4 weeks, but this is a pretty big work. It's well referenced. It's edited. We've invited the world's experts in nutritional epidemiology to cancer biology to cardiopulmonary experts and even nutritionists to tell this story on how nitrite and nitrate from the diet can be used to restore nitric oxide production. So with that, I think that's the end of my slides. I think we may have time for a few more questions. Or
We're going to have the speakers forum tomorrow.
Oh, okay, great. Well, thank you very much.
Thank you, Dr. Nathan. We really enjoyed your research.